from the beginning. My name is Alexey Kalmykov. I'm a professor of the Department of Internal and Occupational Diseases of Kharkiv National Medical University. And today I'm happy to meet you. As far as I know, it's first time of our meeting at the lecture in the subject of internal medicine. And the lecture is dedicated to arterial hypertension. As far as I know, you are third-year students of Kharkiv National Medical University, specialized in dentistry, right?
Yeah.
Yeah, great.
Yes.
So please feel free to raise your hand. I'll hear the Zoomer, and or maybe just simply interrupt me if it is urgent, and ask your questions and make your proposals, comments, etc. I would be happy to have some interaction with you. I'm sorry for this case. I simply didn't check that I haven't checked that I didn't turn on my microphone before. So let's begin from the first idea. I'll try to brush up this quickly for you. So hypertension is not someone's else problem for dentistry. I'm happy to try and represent my own understanding of this matter as in application to dentistry, the worldwide standards of approach to it, so that I hope in your future or even present practice you will be aware and be competent in this relation, in the relation of the how can you, for one hand, adjust your dental care in patients with in terms of hypertension, right? And for other hand, how can you help these patients with hypertension in general? Because you might be if not only, but most often doctors, medical personnel who contacts with these people, and you may save lives for them even. Let me explain. Arterial hypertension is one of the most common systemic diagnoses we usually meet. And it directly changes procedural safety, stress response, bleeding control, anesthetic choice, postoperative analgesics, probability of emergencies, etc. For me, for us, with you, the goal of this lecture is has at least practical component. When a patient sits in the chair, dental chair, you'd likely be able to measure blood pressure correctly, recognize when today's blood pressure is acceptable for planned care, identify red flags for symptomatic or secondary hypertension, and act correctly if a hypertensive crisis develops. I would also want you to think like clinicians. A blood pressure value is not a label, it's a physiological state, physiological condition. It can be transient in case of pain on anxiety, or chronic in case of vascular remodeling. And the management differs. Throughout the talk, I'll do my best to translate internal medicine concepts into dental workflows. History questions that matter, medication interactions you can accidentally trigger, and emergency actions that are appropriate in a dental office. By definition, um, hypertension is stated when the systolic blood pressure exceeds 139 and or diastolic blood pressure exceeding 89 millimeters hydrogram. And equally important, states how the diagnosis is made. Average of 2 and more properly managed seated readings on 2 or more visits. That how is the difference between medicine and noise. Blood pressure is highly sensitive to technique, cuff size, arm position, talking, recent caffeine or nicotine, pain, anxiety. For dental practice, white coat elevation is common. A single reading taken immediately after a stressful arrival can be misleading. The correct approach is see the patient, allow quiet rest, measure with the arm supported at heart level, and repeat to confirm. Be aware that not all guidelines use identical thresholds. European guidance keeps the office definition around equal or over 140 to 90 millimeters hydrogram, while according to American standards, American framework, they label stage 1 starting at 130 to 80 millimeters hydrogram. So, in real life, you may see hypertension statement in the medical record, I mean, even when blood pressure is below 140 to 90 in your chair, because different standards might be used. Clinically, don't argue about labels. Focus on risk, stability, and whether today's blood pressure is controlled for safe care. This table is the classic staging. Normal, below 120 to 80. Pre-hypertension, 120, 139 to 80, 89. Stage 1, 140 to 159 to 90, 99. Stage 2, over 160 to over 100. First, risk rises continuously. Categories are convenience beings, not biological borders. Second, what really matters for the dental chair is not only the category, but the trend and context. If this is a stable treated patient or an uncontrolled patient in pain, a stage 2 number obtained once is in a stressed person may drop after analgesia and calming. But a stage 2 number that persists after rest and repeat management is different and deserves a referral medical input. This is where you practice clinical reasoning. If the patient has severe toothache, pain itself can elevate blood pressure, and you may be safer treating the source of pain with good anesthesia and monitoring than postponing indefinitely. Conversely, if the patient is asymptomatic and persistently very high, you should not push through elective dentistry because you may be the last stressor before a crisis. We will later encore this with dental-specific thresholds and actions. Mm-hmm. Mm-hmm. On this picture, there is a hemodynamic core. Blood pressure is the product of flow, cardiac output, and resistance, arterial tone. You can raise blood pressure by increasing circulating volume, more fluid in the tube, or by narrowing the tube, smaller diameter. And in chronic hypertension, both mechanisms can operate. Early in some patients, especially salt-sensitive or renal-driven hypertension, volume plays a bigger role. That is why diuretics help. In most long-term essential hypertension, the dominant feature becomes increased peripheral resistance due to neurohormonal signaling, sympathetic activation, and renin-angiotensin aldosterone system involvement, etc. And also endothelial dysfunction, less nitric oxide, more vasoconstrictors, and structural alveolar remodeling, thicker vessel walls, smaller lumen, etc. In translation to dentistry, acute anxiety or pain increases the sympathetic output, transiently raising heart rate, contractility, and vasoconstriction. So blood pressure can jump even if a controlled kind of hypertension is present in the patient. That's why the best antihypertensive strategy in a dental chair is often not medication. It's excellent local anesthesia, calm pacing, clear communication, and avoidance of sudden catecholamine surgeries, including inadvertent intravascular epinephrine, etc. This slide says pre-hypertensive individuals are not candidates for drug therapy, but they must be firmly advised on lifestyle modification. And if they also have diabetes or kidney disease, drug therapy may be indicated if lifestyle fails to reduce blood pressure to the value below 130 to 80. The prevention logic is as follows. Elevated blood pressure is a warning state where vascular injury has likely started. But long-term outcomes can still be shifted dramatically. In a dental setting, you see patients regularly and often more frequently than a family doctor sees them. So dental clinics can become important screening points. Practically, when you detect repeated elevated readings, document them. Communicate without alarming. Like, your blood pressure is higher than expected. It would be wise to confirm with your physician or home monitoring, etc. And explain why it matters for both systemic and procedural safety. Lifestyle counseling doesn't require long lectures. One credible sentence repeated consistently, like reduce salt, control your weight, exercise, stop smoking, moderate alcohol. This can enforce medical care and improve adherence. Here the deck divides hypertension into essential. There are more than 95% of all the patients with elevated blood pressure, and secondary with an underlying cause. This is where our topic lies. Many secondary forms create symptoms of characteristic patterns, and most importantly, some are curable or require specific therapy beyond usual blood pressure pills. Essential hypertension is polygenic and environmental driven. Think of it as a complex system disease. Secondary hypertension is detective work. Your job as a future dentist is not to diagnose renal artery stenosis, of course, but to recognize when blood pressure behavior is atypical. Very young onset, abrupt onset, sudden worsening after years of stability, resistant hypertension despite multiple drugs, episodic spikes with palpitations, sweats, hypokalemia history, signs of endocrine disease, etc. When you recognize these patterns, you add value by prompting a referral and by treating dental pain or stress in a way that avoids triggering hypertensive surges. Renal causes dominate secondary hypertension. Chronic parenchymal disease and renovascular disease are main types of these disturbances. Mechanistically, kidney disease activates sodium retention and renin-angiotensin-aldosterone system signaling, volume plus vasoconstriction. Renovascular disease adds a false low perfusion signal driving renin release. Endocrine causes are high yield because they can be dramatic. Primary aldosteronism, often hypertension, low potassium, muscle weakness, cramps. Then, thyroid disorders, tachycardia and systolic hypertension in hyperthyroidism, and diastolic elevation in hypothyroidism. Cushing syndrome, central obesity, bruising, glucose intolerance, pheochromocytoma, episodic headache, palpitations, sweating, panic-like attacks, etc. If in dental translation, endocrine forms can create blood pressure lability. If a patient reports episodic attacks of palpitations and sweating, you should be conversative with stressors and vasoconstrictors until they are medically evaluated. Also, with you should also remember iatrogenic secondary hypertension, use of non-steroid anti-inflammatory drugs, symptomatic cold medicines, oral contraceptives, and some supplements are common contributors. This will return on the resistant hypertension. This list: age, sex, postmenopausal woman, family history, sedentary lifestyle, psychosocial stress, smoking, diet, obesity, diabetes, hyperlipidemia, alcohol, describes the cardiometabolic cluster. The deeper point is synergy. These factors don't add risk linearly. They amplify each other through insulin resistance, inflammation, endothelial dysfunction, and sympathetic activation. For you as the dental students, there are at least two practical applications. First, these same patients often have periodontal disease, impaired wound healing, especially with diabetes, and higher risk with infections. So systemic assessment improves dental outcomes. Second, psychological stress is explicitly on the list. Dentistry itself can be a stressor. That means your behavior and clinic workflow are medical interventions, predictable steps, adequate anesthesia, short sessions for anxious patients, and early morning appointments can lower catecholamine load and reduce blood pressure spikes. Treating hypertension in the chair begins with treating fear and pain competently. This slide is the why we care map. Heart, left ventricle hypertrophy, angina, myocardial infarction, heart failure. Brain, stroke, transitory ischemic attack, chronic kidney disease, peripheral artery disease, retinopathy. These are main problems associated with arterial hypertension. Arterial hypertension is dangerous because it injures vessels and accelerates atherosclerosis. Over time, it remodels the heart and damages microcirculation in brain, kidney, retina, etc. In terms of dentistry, target organ damage is your risk stratifier. A patient with uncomplicated, well-controlled hypertension is usually routine. A patient with a prior stroke, unstable angina, decompensated heart failure, or advanced chronic kidney disease is not routine, even if the blood pressure number today is only mildly elevated. So, the history must include chest pain with exertion, dyspnea, orthopnea, prior myocardial infarction or stents, neurologic events, kidney disease, visual symptoms, etc. These conditions also include and influence drug choices, analgesics, antibiotics dosing in chronic kidney disease, and procedural planning, stress reduction, monitoring, hemostasis strategies, etc. Arteriosclerosis, kidney damage, heart attack, stroke, enlarged heart, blindness. This is the clinical end game of chronic pressure injury. Mechanistically, constant high pressure causes endothelial micro tears and dysfunction. Low density lipoproteins infiltration and lipids infiltration and inflammation accelerates plaque. Small arteries thicken and narrow, impairing perfusion. In the kidney, glomerular pressure injury causes proteinuria and progressive loss of filtration. let me think what I wanted to say. Just few seconds, dear colleague. I need to do something. Every day at this time, we appreciate those people who...
Вспомните ковид, февраль 2020 года. Вроде бы это где-то рядом, но все же это не про нас.
Just one moment. Just few seconds. Just few seconds of pause, please. Thank you. Just a few seconds. I'll return to our lecture. Traditionally,
Вспомните ковид, февраль 2000.
use such pauses every day at 9 a.m. to appreciate those who have been killed in our war. Just a few seconds. I'll return to the lecture. Yeah, I'm back. So let me read what we are talking about now. Okay. In the heart, afterload induces hypertrophy. Coronary supply can't keep up, and diastolic filling worsens. Arrhythmias become more likely. For dentistry, this means uncontrolled hypertension is often a marker of silent disease elsewhere. If you detect persistent high blood pressure, the patient is not just at risk. During your procedure, they are at long-term risk of stroke and myocardial infarction. The dental visit becomes an opportunity for prevention. A respectful referral may prevent a catastrophe. Also, consider that hypertensive patients may be on antiplatelets, anticoagulants due to vascular disease. So your bleeding risk assessment must be individualized. This slide shows a thickened left ventricle without massive overall enlargement. Classic hypertensive heart disease. The myocardium hypertrophies to generate higher pressure against increased afterload. Early on, this preserves systolic function. But it comes at a cost. Reduced compliance, stiff ventricle, impaired diastolic relaxation, higher filling pressures, and eventually left atrial enlargement and atrial fibrillation risk. Clinically, these patients can have exertional dyspnea, reduced exercise tolerance, and episodes of chest discomfort, even without coronary stenosis, because the hypertrophied heart has higher oxygen demand. Dental implications are as follows. Avoid provoking tachycardia and blood pressure surges. They raise myocardial oxygen demand. Ensure profound anesthesia before painful stimulation. More gradually from supine to sitting. Diastolic dysfunction and medications can predispose to dizziness. If the patient reports recent angina, unstable symptoms, or decompensated heart failure, elective dentistry should be deferred and coordinated with medical care. This is the long untreated years phenotype. Marked hypertrophy and often accompanying interstitial fibrosis. Fibrosis is clinically important because it disrupts electrical conduction, predisposing to arrhythmias, and reduces contractile reserve. These patients may develop heart failure with a preserved ejection fraction, or where the heart pumps but feels poorly, causing pulmonary congestion during stress. In the dental chair, this translates into lower tolerance for sympathetic surges, fluid shifts, and hypoxia. If a patient with severe hypertension develops acute dyspnea, cough, or frothy sputum, think pulmonary edema. This is a hypertensive emergency pattern. Again, dentistry is not the place to treat the number. It is the place to recognize a dangerous physiology and activate emergency pathways. The retina illustrates microvascular injury visually. Hemorrhages, heart exudates, lipid deposits, cotton wool spots, microinfarcts. Retinopathy signals that hypertension is not just high pressure, it is end organ disease. Severe retinopathy, especially with papillary edema, not pictured here, but classically in malignant hypertension it happens, indicates dangerous systemic vascular injury and is associated with hypertensive emergencies. In a dental context, you won't diagnose retinopathy, but you should respond to symptoms: new blurred vision, visual field loss, severe headache, confusion, especially with very high blood pressure, suggest acute target organ involvement and requires emergency evaluation. This fits the later definition. Hypertensive emergency is not defined by blood pressure alone, but blood pressure plus acute organ dysfunction. This slide states the key truth. Hypertension is usually asymptomatic. It is silent killer. When symptoms occur, they are non-specific. Morning occipital headache, dizziness, fatigue. Severe hypertension can cause epistaxis or blurred vision. The clinical aspect is to distract symptoms as screening tools. Adherence to absence of symptoms doesn't mean blood pressure is safe, and presence of you see, just a moment. I just looking forward about the time. We had started at 8. If you don't mind, let us not make the break, please. It's my proposal because we have missed so much time already.
Okay.
Thank you. So, dental pain itself can mimic systemic symptoms, fatigue, dizziness, headache, while simultaneously rising blood pressure. So, your workflow should be measure, repeat, assess context, pain, anxiety, and ask symptom-focused red flags. Chest pain, dyspnea, neurologic deficit, visual loss. If red flags exist, the priority shifts from dentistry to emergency care. I'd like to introduce a critical conceptual split. Hypertensive urgency. It's when severely elevated blood pressure without progressive target organ dysfunction. Hypertensive emergency, when there is severely elevated blood pressure with progressive organ dysfunction. This is not semantics. It changes what exactly you do. In emergencies, blood pressure lowering must be controlled and monitored because overly rapid reduction can precipitate ischemia in brain, heart, kidney, eyes. The dental translation is straightforward. You do not attempt pharmacologic blood pressure control in the clinic for suspected emergency. You identify target organ symptoms and call for urgent medical evaluation. Your triage is based on symptoms and signs, not on the number alone. A calm patient with very high blood pressure but no symptoms may be urgency. A patient with moderate elevation but neurologic deficits is an emergency until proven otherwise. Here, severe blood pressure in the upper stage 2 range without progressive organ dysfunction, often due to under-controlled hypertension. The most common real-world causes are missed medications, pain, anxiety, alcohol, and interacting drugs. The dental decision is nuanced. If pain is driving blood pressure up, definitive pain control local anesthesia, drainage of abscess when indicated, etc., can reduce sympathetic activation and may be safer than postponing, provided your monitor and the patient remains asymptomatic. There are also pragmatic thresholds. If confirmed systolic blood pressure 160 to 180 and or diastolic blood pressure 100 to 109, pain contributes contributes this. You can proceed with emergency care with blood pressure monitoring during the procedure and anxiety reduction techniques. If confirmed systolic blood pressure over 180 and or diastolic blood pressure over 109, seek physician consultation before proceeding. In all cases, repeat measurement and documentation matter, because one reading is often an artifact. This slide states the blood pressure exceeding 180 to 120 with progressive organ dysfunction and the need for emergent lowering, giving classic examples: encephalopathy, acute left ventricle failure with pulmonary edema, acute myocardial infarction, unstable angina, and aortic dissection. In the dental office, your treatment is emergency protocol. Stop your procedure, position the patient, monitor vitals, give oxygen if needed, and activate emergency medical service. Oxygen is broadly indicated in dental emergencies except hyperventilation. In adults, typical flows are 6 to 10 liters per minute by mask when breathing spontaneously. Importantly, do not give sublingual nifedipine for rapid blood pressure reduction. This is no longer recommended because it can cause uncontrolled hypotension and ischemic events. Your role is stabilization and transfer, not pharmacological blood pressure manipulation. The routine tests listed: electrocardiogram, urinalysis, glucose, potassium, creatinine, and evaluation of glomerular filtration rate, calcium, fasting lipid profile, define baseline cardiovascular and renal risk, and look for hypertension-mediated organ damage. Optional urine albumin creatinine ratio, is a sensitive marker of vascular kidney injury and strongly upgrades risk. The slide also notes that the extensive testing for causes is usually not indicated unless blood pressure control is not achieved. That is a key cost-effective principle. Screen broadly for damage and risk, then pursue secondary causes when the phenotype suggests it. Resistant hypertension, abrupt onset, severe disease, hypokalemia, or so. Dentistry application. You should recognize what these tests imply. Reduced glomerular filtration rate changes drug dosing and bleeding risk. Diabetes changes infection risk and healing. Electrocardiogram evidence of left ventricle hypertension suggests chronicity. Albuminuria signals about high vascular risk. You don't order these tests as a dentist in many systems, but you should understand the medical language when a patient reports results. Treatment overview. This slide breaks management into goals, lifestyle, pharmacology, an algorithm, and follow-up. This is exactly the structure you should use when you explain hypertension to a patient briefly. We treat to prevent stroke, heart failure, and kidney failure. Lifestyle lowers blood pressure and reduces medication need. Medications are tailored. Control is reassessed and intensified, and monitoring ensures safety and adherence. For you as dental students, the practical add-on is as follows. You must know the common antihypertensive drug classes because they influence oral health. Xerostomia, gingival changes, etc. They interact with dental drugs, non-steroid anti-inflammatory drugs, and change hemodynamic responses in the chair. I mean orthostatic hypotension. Also, the dental visit is a real adherence checkpoint. Patients often skip morning medications when fasting or anxious. A simple question is like, did you take your blood pressure medications today? Can prevent a procedural complication. On this slide, there is stated that target blood pressure below 140 to 90 for most and 130 to 80 for diabetes or patients with chronic kidney disease. Targets do vary across guidelines and patient risk profiles, but the principle is stable. Lower blood pressure to reduce cardiovascular and renal morbidity and mortality. European guidance, for example, emphasizes getting below 140 to 90 in all first, then aiming towards around 130 to 80, if tolerated in many patients. Younger patients may benefit from lower systolic ranges if safe. Avoid turning targets into ideology. Instead, understand individualization. Older, frail patients may not tolerate aggressive lowering. Patients with diabetes or chronic kidney disease are high risk and often need tighter control. And treatment is balanced against side effects. I mean electrolyte disbalance, renal function, orthostatic symptoms, etc. In terms of dentistry practice, the better control the blood pressure over time, the lower the procedural risk. But also remember, a controlled blood pressure today does not eliminate risk in target organ disease exists. You still tailor stress reduction and monitoring accordingly. This stair-step slide is excellent for patient education. Start with eliminating harmful exposures, smoking and excess alcohol. Then dietary sodium reduction and reduction of high-fat processed foods. Then weight loss if obese and regular aerobic activity. Finally, the so-called DASH, D-A-S-H, dietary pattern. Add two modern points, sleep and stress. Obstructive sleep apnea is a major driver of resistant hypertension. Chronic stress increases sympathetic tone and worsens adherence. For dental practice, you are uniquely positioned to notice sleep apnea risk, daytime sleepiness, loud snoring history, large neck circumference, and to reinforce a consistent lifestyle message. Also, lifestyle changes improve periodontal inflammation and metabolic status, so dental and cardiovascular outcomes align. The question is lifestyle really enough? As for me, the correct answer is lifestyle is the foundation for everyone. And in early stages, it can be decisive. In an advanced disease, it reduces medication burden and improves outcomes when even in case when drugs are required. The DASH diet. This slide summarizes DASH. Fruits, vegetables, low-fat dairy. It's like a dietary approach to stop hypertension. Yeah, DASH. Fruits, vegetables, low-fat dairy, and overall reduced saturated fat pattern lowers blood pressure in both hypertensive and high normal individuals. To remember it well, emphasize that DASH is not a restriction diet. It is a composition diet. More potassium, magnesium, calcium, fiber, and lower sodium density via whole foods. It also indirectly promotes weight control because of safety and reduced ultra-processed intake. For a dental aspect, I would frame DASH as a practical prescription that also supports oral health. Fewer sugary processed foods, more whole foods, and better metabolic control. The modern standards describe DASH as a flexible, balanced eating plan specifically designed to support blood pressure reduction and heart-healthy patterns. Use that wording when you teach your patient because it is evidence-based and non-judgmental. Servings make DASH actionable. Grains, vegetables, fruits, low-fat dairy, limited meat, modest fats, nuts and beans several times per week, limited sweets. People often underestimate the fruit to vegetable and vegetable targets. 4 to 5 servings each is more than most people eat. Your possible approach to educate your patient is to translate servings into real objects. Half your plate vegetables, or fruit twice per day minimum, or dairy low fat if tolerated, or beans and nuts as protein a few times a week, or treat sweets as occasional, or something like that. There is also a reason to mention sodium pragmatics. The fastest sodium reduction comes from reducing processed foods, not from removing the salt shaker alone. In a dental care, this matters because patients may ask about diet after procedures. Your advice should not conflict with cardiovascular advice. A short, consistent message, which might be useful, is like soft foods can still be dash if you choose yogurt, mashed beans, vegetable soups without added salt, and fruit smoothies without added sugar. These words or these ideas are both dental and cardio compatible. This slide lists common first-line classes with example doses: thiazide diuretics, beta blockers, calcium channel blockers, alpha blockers, angiotensin converting enzyme inhibitors, antagonism of angiotensin again receptors or blockers, blockers of receptors angiotensin. These are main groups of these medications. Our main point is not memorizing doses even. The main is to understand mechanisms and predictable adverse effects. The dentistry facing highlights are, for example, many antihypertensives contribute to xerostomia, which increases caries risk and affects denture comfort. Or calcium channel blockers can be associated with gingival overgrowth, complicating periodontal status. Or non-steroid anti-inflammatory drugs, which dentists often prescribe, can raise blood pressure and blunt the effect of several antihypertensives, particularly angiotensin converting enzyme inhibitors or angiotensin 2 receptor blockers, and even diuretics. So prolonged non-steroid anti-inflammatory drugs courses in hypertensive patients require caution. Or polypharmacy increases orthostatic hypotension risk. So post-procedure position changes should be slow. This algorithmic table links blood pressure stage, lifestyle, and medication choices, adding compelling indications. The key idea is reasonable escalation. Lifestyle for all, monotherapy or combination depending on severity and risk, and tailoring to comorbidities. Compelling indications means choose drugs that treat both blood pressure and the underlying cardiovascular disease. For example, angiotensin-converting enzyme inhibitors or angiotensin receptor blockers in diabetes with albuminuria, or beta blockers in coronary disease, specific regimens in heart failure, etc. In modern care, combination therapy is often introduced earlier for stage 2 because it improves control and reduces time spent uncontrolled. For dentistry, the practical relevance is medication reconciliation. Identify the class, ask adherence, and anticipate side effects. If a patient is uncontrolled despite multiple agents, that is also a sign to consider secondary causes of or adherence problems, both of which affect procedural risk and should prompt medical follow-up. Diuretics. This slide explains thiazides. Acute effect is reduced blood volume and cardiac output. Chronic effect is reduced peripheral resistance. They are often effective in older patients and salt-sensitive hypertension. Side effects are clinically important. Hypokalemia and hyponatremia can produce weakness, cramps, and rarely arrhythmia risk. Hyperuricemia can trigger gout. Glucose and lipid effects matter in metabolic syndrome. And then they may be problematic in significant renal or hepatic insufficiency. In translation to dentistry, ask about dizziness on standing. This means this might be related to volume depletion. And be careful after long procedures. Orthostatic hypotension is a real post-chair event. If the patient reports muscle cramps or palpitations, that could be electrolyte related and deserves medical review. Also, xerostomia can be exacerbated by diuretics, increasing caries risk. This is where preventive dentistry, fluorine, saliva substitutes, hydration counseling becomes part of systemic risk care. Beta blockers. This slide describes beta blockers reducing cardiac output and inhibiting renin release, particularly useful with coexistent coronary disease. Side effects include lethargy, impotence, bradycardia, and cautions in asthma and diabetes. Dentistry-specific safety issues are interaction with epinephrine in local anesthetics, especially in patients taking non-selective beta blockers, because beta blockade can remove peripheral beta-mediated vasodilation, leaving alpha vasoconstriction unopposed, producing marked hypertension and reflex bradycardia if epinephrine is inadvertently injected intravascularly or used in high dose. The practical response is not to avoid local anesthesia. It's to use careful technique, aspirate, inject slowly, use the lowest effective epinephrine concentration or dose, and monitor. The modern medicine's guidance explicitly modern standards guidance explicitly advises with limiting adrenaline containing cartridges with non-selective beta blockers and explains the unopposed alpha mechanism. Also remember, beta blockers can mask hypoglycemia symptoms in diabetics, relevant if a patient skips meals for dental appointments. Calcium channel blockers block calcium entry and causing vasodilation and reduced peripheral resistance. Dihydropyridines like amlodipine are common. They have neutral glucose lipid effects and are often used in all the patients and those with asthma, where beta blockers may be limited. Side effects include flushing, headache, and pedal enema. Enema is a frequent reason for non-adherence. Dentistry specific point is gingival overgrowth can occur with some of calcium channel blockers, which can mimic or worsen periodontal disease. The correct management is multidisciplinary. Improve plaque control and periodontal therapy and coordinate with the prescribing clinician. Sometimes drug substitution or dose adjustment helps. It's a good idea to ask the patient neutrally. For example, have you noticed swelling or gums since swelling of gums since starting this medication? This is a good example of how systemic pharmacology becomes visible in mouth. ACE inhibitors, so angiotensin converting enzyme inhibitors, they reduce angiotensin II formation and are first choice in diabetes and heart failure because they protect kidney and heart beyond blood pressure lowering. Classic side effects are dry cough, hypotension, angioedema. These are main. For dentistry, angioedema is the critical safety pill. Angiotensin converting enzyme inhibitor induced angioedema can present as swelling of lips, tongue, face, and can involve the airway as well. It can occur even after long-term use, not only in the first week. If a patient arrives with unexplained facial or oral swelling and is on an ACE, angiotensin converting enzyme inhibitor, treat it as a potentially serious airway problem. Do not assume it is a simple dental allergy or infection without assessment. This is exactly where dentists must think like physicians. Airway risk beats dental diagnosis. Angiotensin 2 receptor blockers. They block the angiotensin 2 receptor. They share many benefits of angiotensin converting enzyme inhibitors and are often used when angiotensin converting enzyme inhibitors cause cough. Then can still cause hypotension and can contribute to hyperkalemia, particularly in chronic kidney disease or when combined with potassium sparing agents. In dentistry, angiotensin 2 receptor blockers are generally well tolerated. The key is interaction awareness. Non-steroid anti-inflammatory drugs can reduce the antihypertensive effect and impair renal perfusion, especially when combined with renin, angiotensin, aldosterone system blockers and diuretics, the classic triple whammy risk for kidneys injury. So, prolonged non-steroid anti-inflammatory drug prescribing should be cautious in hypertensive patients on angiotensin converting enzyme inhibitors or angiotensin 2 receptor blockers plus diuretic, and patients with chronic kidney disease deserve extra care. The safe habit is choose the shortest effective non-steroid anti-inflammatory drug course or consider alternatives when risk is high. Alpha blockers. Alpha-1 blockers cause vasodilation, reduce peripheral resistance, and are useful when blood pressure hypertension is present. Their signature adverse effect is postural hypotension, especially at initiation or dose increase. In dental practice, postural hypotension is a common and preventable event. Patients stand up quickly after a long supine procedure and become dizzy or faint. The preventive strategy is simple. Raise the chair gradually, pause, ask for how they feel, and allow a moment seated before standing. If symptoms occur, return to a safe position, check vitals, and provide oxygen if indicated. An educatory point for patient is the fact that medication side effects are not theoretical. They appear as chair-side events. Algorithm. This flowchart emphasizes interactive care. Lifestyle first. Choose initial drugs based on stage and competing indications. Reassess, optimize doses, or add agents until goal achieved. And consult specialists if uncontrolled. Two deeper aspects. Accurate measurement is part of therapy. Mismeasurement produces over-treatment or under-treatment. Second, adherence is a clinical variable, not a moral trait. Many resistant, supposed resistant cases are actually non-adherence, side effects, or interacting drugs. dentistry can support the algorithm by reinforcing adherence. You may do it by words like take your usual blood pressure meds on procedure day unless your physician told you otherwise. By identifying uncontrolled readings and by avoiding prescriptions that worsen blood pressure control. I'd like you to think clinically. And the main question, as for me, in this relation is, what are 3 most likely reasons my patient is still not at goal? Measurement, adherence, or drug interactions before care causes. This table is intended to implement individualization. Asthma favors calcium channel blockers or angiotensin receptor blockers over beta blockers. Diabetes favors angiotensin converting enzyme inhibitors or angiotensin receptor blockers based regimens. Elderly often respond to diuretics and calcium channel blockers. Blood pressure hypertension favors alpha blockers. The important point is that hypertension is not one disease, or maybe not one disease, drug choice, and the choice depends on comorbidity and tolerability. For dental care, for dental sphere, comorbidity drives procedural planning. Asthma changes sedation and stress management. Diabetes changes infection control and healing. Elderly status increases orthostatic risk. Blood pressure hypertensive drugs increase hypotensive risk, hypertension risk. When you see the medication list, you can often infer the comorbidity. Use that to ask smarter history questions and anticipate chairside complications. This slide is a compact safety checklist. Non-dehydropyridine calcium channel blockers like diltiazem can worsen bradycardia, conduction disturbances, and some heart failure states. Important because many patients simply say, I take a calcium blocker without knowing which one. Angiotensin converting enzyme inhibitors or angiotensin receptors blockers are contraindicated in pregnancy and bilateral renal artery stenosis. Alpha blockers are associated with postural hypotension. As a clinician, you use this information in 3 ways. Anticipate symptoms, dizziness, cough, edema. Second, interpret emergencies correctly, angioedema, infection, and coordinate care when dentistry may change physiology. Long procedures, blood loss, dehydration, analgesic prescriptions. Emphasize to yourself, medication history is not a formality. It's a risk model. This slide highlights special populations. Pregnancy, nifedipine, labetalol, hydralazine, methyl dopar are classic options. angiotensin converting enzyme or angiotensin receptor blockers are avoided. In coronary heart disease, beta blockers, angiotensin converting enzyme inhibitors, and some calcium channel blockers are common. Congestive heart failure, angiotensin converting enzyme inhibitors and beta blockers are core disease modifying therapy in many phenotypes. For dentistry, pregnancy adds two considerations: avoid teratogenic antihypertensive exposure. That's the physician's job, actually. But recognize that pregnant hypertensive patients may have higher risk states and require careful stress reduction and positioning. Coronary heart disease and chronic heart failure mean the patient's myocardium has less reserve. Keep appointments short, ensure profound analgesia, and avoid unnecessary catecholamine surges. If vasoconstrictor is needed, use the lowest effective dose. Many dental references describe a conservative cardiac dose limit of epinephrine around 0.04 milligram per appointment in patients with significant cardiovascular disease, emphasizing careful technique and monitoring. This slide is a strong clinical finish because it emphasizes realism. Resistant hypertension is often not mystery biology. It is measurement error, excess sodium, inadequate diuretic therapy, medication issues, insufficient doses, interactions, excess alcohol, drugs, supplements, side effects, symptomatic, and only then identifiable secondary causes. Dentistry intersects directly here through prescribing and making advice. Non-steroid anti-inflammatory drugs are a major example. They can destabilize blood pressure control and antagonize the effects of angiotensin converting enzyme inhibitors, angiotensin receptor blockers, and diuretics, partly via renal prostaglandin inhibition and effects on the renal perfusion and sodium retention. So, if you prescribe non-steroid anti-inflammatory drugs repeatedly or for long courses to a hypertensive patient, especially one on angiotensin converting enzyme inhibitors or angiotensin receptor blockers, plus diuretic, you may worsen both blood pressure and kidney function. A safer dental habit is to use shortest effective non-steroid anti-inflammatory drugs duration. Consider acetaminophen-based regimens when appropriate, and communicate with the physician when risk is high. Finally, and with the clinical mindset. When blood pressure is uncontrolled, do not only add another drug. First, verify measurement, adherence, salt intake, alcohol, and interacting medications. Thank you. Sorry for today's these time shifts. I really was confused. Thank you for coming.
Thank you.
I'm not sure we'll meet some other time. So I kindly invite you, if you are interested into student scientific independent work. I'm the person responsible at our department for scientific work in everyone.
Nice to meet you.
So you are welcome. If you have any now or later any questions, feel free to contact me. And
Okay.
I have an experience of very interesting students, researchers, exactly in dental students. I mean, specialized in dentistry, in terms of these joint aspects. You see, between internal organs condition and dental practice. So it might be useful for you from both scientific, educational, practical point of view. Some of my students even have their own business, or they start late after graduation from the university. And we may also talk about some entrepreneurial aspects even now, before you start your own practice. So I'm open for such a cooperation with you. You're welcome. Thanks.
Thank you.
Thank you so much.
Bye. Good luck.
Kayıt
See you
için, modul kaydı için şey mi istesek, link mi istesek?
Could you repeat, please?
The model for model platform text note need a link.
But you have it. Look here. Do you see my screen clearly? Yes? Do you see my screen?
Sorry.
I have sent.
Benim ekran çalışmıyor ya. Ah.
Do you see now?
Yes,
I'm
I
just
have.
look here.
Neyse, bu araya girsene, benim ekran dondu.
In
I
the
have.
invitation at the very end of
Beni
description,
atacak birazdan.
I send you direct link. You see?
Please,
Okay,
please.
yes.
Like I already have sent you. You have it already in your invitation for today's class, for today's lecture. I will repeat it for you, of course. Here it is.
Çabuk.
And I have recorded today's lecture. I'm inclined to upload it to my YouTube channel and send you the link. Okay?
Okay, thank you so much.
Thank you. See
Bye
you.
bye.
Bye. Good luck.
See you.